All right, I'm going to go ahead and get us started. My name's Susanna Baruch. I'm the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. Welcome to today's event. Before we really kick off, I just want to go over a few housekeeping items. During this webinar, the chat will not be functional, but you can submit questions, and we encourage you to do so anytime using the Q&A feature in the meeting controls at the bottom of your screen. You can join the conversation on Twitter at Petrie-Flom. We will be sharing a fully captioned event video with all registrants within a couple of weeks of today. If during the webinar you have any technical issues, please email us at petrie.flom@law.harvard.edu, and we will do our best to help. If you are interested in Petrie-Flom Center's upcoming events, news, or education programs, you can sign up for our newsletter, read our blog, Bill of Health, check out other upcoming events, or listen to our podcast, Petri Dishes. If you are interested in the Harvard Center for Bioethics, applications are still open for the Master of Science in Bioethics degree program and the Fellowship in Bioethics. You can find information for both centers at the QR codes or on our websites. So Petrie-Flom is a research center at Harvard Law School, and we focus on the unbiased legal and ethical analysis of pressing questions in health law and conducting interdisciplinary and legal scholarship. Thank you to our colleagues and friends at the Harvard Medical School Center for Bioethics and Portal, the program on regulation, therapeutics, and the law at Brigham and Women's. This event is part of the Health Policy and Bioethics Consortia, which is a monthly series and is organized by all three centers. So today's topic, as you know, is unionization in healthcare. And by way of introduction, before I get to our speakers, I want to ask you to imagine something for a moment. Imagine that you are a Martian. You're a creature from another planet. We're going to say it's like a year ago, February 2023. Your spaceship lands somewhere in the United States. And while climbing out, you experience full Earth gravity for the first time, and you fall hard, and you hurt your Martian ankle, if Martians have ankles. So the question is, as you seek treatment for this injury, what would you learn about us as a country? You might go to a hospital or urgent care center and wait for a long time for an X-ray or a cast due to staff shortages. You might be advised to see a primary care doctor, even though it's literally impossible to find one in many parts of the country. And probably like most of us, you would muddle through, but you would see that this system is truly stressed. Would you think, as an outsider, that the way we are doing healthcare is adequate or sustainable? Just a snapshot in time, in June 2023, Mass General Brigham's residents and fellows voted overwhelmingly to form a union. In October 2023, tens of thousands of unionized workers at Kaiser Permanente walked out in the largest healthcare strike in American history. We know that the COVID-19 pandemic took a toll on physicians and nurses and other critical staff. This is a profession known for challenging training and life and death decision-making, but it was something else. And now we see clinicians retiring early, seeking other jobs, facing compressed schedules, and having to cope with new rules and new ways of practicing. We see huge staffing shortages, especially in primary care. So this is all by way of background. Petrie-Flom wanted to consider unionization in healthcare as one possible strategy to address some of these challenges, while also asking about the legal and ethical issues that unionization creates. So today you will learn about the basics of labor law, the history of organizing, and we will explore some of these ethical concerns. And we're intentionally focused on the future of medicine by thinking specifically about physicians in training, like residents and fellows and interns. So let me introduce our two speakers. Our first speaker, Steve Ury, is the general counsel of the Service Employees International Union, where he directs the legal program for the 2 million members of the union. Steve has spent his career fighting for the rights of workers to organize. He began as a union organizer in Louisiana, Arkansas, and Texas. And after 5 years in private legal practice, Steve joined the SEIU legal department in 2003. So for the last 20 years, Steve has held a number of positions, including Deputy Director of the South-Southwest Region, Lead Healthcare Counsel, Deputy General Counsel, and now General Counsel. Steve is a graduate of Yale University and New York University of Law. Our next speaker after Steve is Ahmed Abid, who is a resident physician and researcher at Brigham and Women's Hospital. He has led multiple investigations on the prevalence and impact of unionization on healthcare workers, leading to publications in JAMA. He is currently leading efforts to understand the history of unionization among physicians in training and the impact of unions on patient outcomes. Ahmed was named in 2023 a Stat Wunderkind, which recognizes the next generation of scientific superstars. He earned his bachelor's degree from Cornell and his master's in public policy and education at the University of Oxford as a Rhodes Scholar. He holds an MD from Harvard Medical School, where he studied as a Soros Fellow and Presidential Scholar. I will turn it over to Steve.
Thanks so much, Susanna, and it's great to be here. Thanks so much for having me. I'm very interested to get into this discussion. I'm going to talk a little bit about my union, SEIU, the Service Employees International Union, what we do. And then I'm also going to give an overview of how unionization works, how you form a union, why you would form a union, and trying to be specific to the healthcare sector. So I'm going to put up some slides here. Oh, hold on. All right, so who are we, the SEIU? We are a union of 2 million members. About half of those members are healthcare members. And we have members across the United States and Canada, but with 1 million healthcare members, we are the largest healthcare union in the United States. Some of our well-known affiliates include Local 1199, the Committee of Interns and Residents, UHW, or United Healthcare Workers West, and the SEIU Doctors Council, but we have many affiliates across the country that work with healthcare workers. We represent employees in all sorts of areas of healthcare, pretty much everything that's out there, public and private hospitals, clinics, nursing homes. We represent home care workers and state and local health departments. And within those facilities, we represent almost every kind of healthcare worker, doctors, house staff, service workers and techs, EMTs, RNs, LPNs, CNAs, maintenance workers, clerical workers, professional workers like pharmacists and physical therapists and home care workers. And since we are going to talk somewhat specifically about house staff unions, I wanted to mention a little more specifically how our house staff unions work. House staff unionization, by the way, is nothing new. It dates back to 1934 when the Intern Council of Greater New York formed. And their goal was to get compensation for house staff in New York. In 1999, house staff were recognized in the private sector as employees who could unionize. And our affiliate, the Committee of Interns and Residents, represents house staff unions. And they have 30,000 members. That's about 20% of house staff nationally at more than 70 hospitals. And since the pandemic, there's been a real surge in organizing among house staff. Our house staff membership's grown about a third since the pandemic, and by about a third. And just a couple of weeks ago, the latest addition was Northwestern University, whose house staff voted to unionize. So I want to turn now to why do people unionize? Why form a union? Well, there are a number of reasons. The most obvious and the most well-known are wages and benefits and working conditions, right? And for healthcare workers, there are some specific working conditions that they're concerned about, often overlapping with patient care. Staffing ratios, right? How many patients can a resident or a nurse be assigned per shift? During the pandemic, having adequate PPE was a huge issue. Having access to vaccines when they came out, right? These are the things that healthcare workers and house staff have told us that they want. For house staff, call rooms are a huge issue. Adequate sleeping space so that when they're on a 24-hour shift, they don't have to sleep in a chair somewhere, right? But for all of these tangible reasons, there are also intangibles, right? And I put those under the heading of dignity and respect. People want to feel respected where they work. They want to have dignity in their work. And they want to feel that from their employer. And a union is one way to feel that. And I would say that in campaigns I've worked on, those intangible issues are often almost as important as the tangible issues, as wanting better wages and benefits. People want to feel some amount of self-worth while they're working. Protection and job security are other issues. Protection can be from discrimination or harassment. There are other legal venues to address those issues, but a union is one way to do it, and sometimes can do it very effectively and sometimes more cheaply than through the legal process. Protection from arbitrariness as well, right? In almost everywhere in the United States, we have at-will employment, right? Which means that you can be fired for an arbitrary reason. You can be fired for any reason or no reason at all, unless you're being discriminated against based on, a narrow group of protected classes like race or gender or religion. There's no protection or right or recourse from arbitrary actions by an employer. And when you have a union, that's not the case. You have a right and you have a recourse. And so it provides that protection. And I would say, lastly, it gives people a voice, right? A union is an equalizer. If you don't have a union, there is nothing that requires a manager to listen to employees, to talk to employees, to deal with employees about their working conditions. And when you have a union, they are required to do that, right? And so it shifts the balance of power between managers and employees. And so these are the sort of my summary of the things we hear about why people want to form unions. So that moves us to how do you form unions, right? How do you go about doing that? And what does it mean for a workplace? So I just first want to clarify that there's a difference between how it's done in the public sector and the private sector, right? So in the public sector, and that means people who are government employees, so county hospitals, state departments of health, public universities, unionization and labor relations for those government employees are going to be governed by state law. And so it can vary quite a bit from state to state. A resident in Massachusetts is going to be subject to very different laws around unionization from a resident in Texas, right? A nurse in California is going to be under a different set of laws from a nurse in Alabama. Suffice to say, we don't have the time here to go through the 50 state laws plus territories that are involved. So I'm going to focus on the private sector. Private sector employees throughout the country are governed by one law, the National Labor Relations Act. The National Labor Relations Act was passed in 1935. It's the law that governs labor relations and unionization throughout the United States, throughout all private sector employers. It was specifically amended in 1974 to include nonprofit hospitals. This was after a wave of hospital organizing throughout the country, but particularly strong in New York with Local 1199 there. And so that amendment then brought nonprofit hospitals in so that now it covers for-profit and nonprofit healthcare employers. The act is administered by the National Labor Relations Board, which is a federal agency that administers the act and all things having to do with unionization and labor relations in the United States. So how do employees at a healthcare facility form or anywhere else for that matter, it's not that different, form a union? There are two ways that I'd say are most common, right? And the first way is what we call voluntary recognition. So if there's a group of employees, and we call this a bargaining unit, and essentially a bargaining unit is a group of employees with a common interest. It can vary from place to place, but it could be all of the nurses at a hospital. It could be all of the employees at a nursing home. But it's employees that have what we call a community of interest together. If there's a group of employees that want to form a union, and a majority of that group wants to form a union, they can then go to management of that employer and request recognition. Say, the majority of us want to form a union. We would like you to recognize us and bargain with us as a union. The employer then has two choices. The employer can recognize the union and deal with the union as the representative of its employees. Or the employer can say, we think there should be an election here. And what they do then is they file a petition with the National Labor Relations Board and ask for a union election. And what happens then is the board sends federal agents to the facility to hold an election among the employees. Sometimes they do it by mail, but very often it's in person. So they will literally come to a hospital or nursing home or other clinic and set up a space. And it's very much like an election when you would vote for a political office, and the employees come in and they there's a polling place and they have a place to vote, a secret ballot where they vote yes for a union or no, we're not a union. And if a majority of those employees vote for the union, then there is a union at that workplace. The second option is that the union can request an election. Instead of asking for recognition from the employer, the union can say, we just want to have an election. And they don't need a majority to do that. They only need support of 30% of the employees to ask for an election. And then the same thing happens. The board agent comes in and holds an election. And if a majority of the employees want a union, then they have a union and they're certified as a union. So you've got a union. And the next thing you do is engage in collective bargaining, right? That's the negotiation process over terms and conditions of employment, where the union sits down with the employer and they talk about what the rules should be, essentially. And they really can talk about any term or condition of employment, right? Wages, benefits, leave policies, hours, scheduling. There's not a lot of limitation as to what they can talk about and what they can agree to. Once they agree, it becomes a collective bargaining agreement, which is a binding contract that is enforceable in court, but more often is enforceable through an alternative dispute resolution process that ends in arbitration. So if someone feels there's been a violation of the agreement, they file a grievance. There are usually several steps, and if the parties can't resolve it, it ends in binding arbitration by a third-party arbitrator. Another aspect of these agreements I want to talk about are labor management committees, because I think there's a sense that labor management relations are contentious always, and sometimes they are, but they don't have to be. And in many agreements, you'll find labor management committees, and that is a committee of workers at the facility and management that meet regularly to address disputes before they happen, but also to address issues that come up in the facility. Frontline workers, in my experience, know very well how to improve things, the way things run at a facility. They often have ideas about how to save money, how to make things more efficient, or they see problems that are coming up before management necessarily sees them. So these types of committees can be very helpful, I think, for both labor and management in running an efficient and safe facility that provides good patient care. So the National Labor Relations Act, which is the law that we talked about around unionization, has protections for employees. Under this law, this is a right, a legal right that employees have to form and join unions, or to engage in concerted activity for mutual aid and protection. What does that mean? That essentially means when employees get together to improve their working conditions. It doesn't have to be through a union. Right? It could be that they send a petition, even if it's not, they don't want a union. They just send a petition saying, we want higher wages. That is something that's legally protected for them to do. They can make demands, they can picket, and ultimately they can go on strike, right? And these are, again, protected legal rights. And violating these rights is unlawful, right? And so it's unlawful for an employer to threaten, intimidate, or coerce employees who support unionization, or to retaliate or punish or discriminate against those employees. It's unlawful for an employer to say, for instance, if you form a union, we're going to lower wages, or we're going to close the facility, or we'll give you a raise if you vote against the union, right? These are all unlawful acts. It's also unlawful for employers to do things that would restrain the right of the employees to organize or form a union. For instance, saying, hey, you can't wear union stickers to work, right? It's actually not well known, but it's unlawful for employers to tell employees that they can't discuss their salary with other employees, right? That's a right of an employee to talk with other employees about what their salary is. So an employer saying you can't do that is a legal violation. And these legal violations, known as unfair labor practices, are enforced by both the National Labor Relations Board, the federal agency, and they're appealable to the federal courts. So that's my quick Unionization 101. I want to step back and talk a little more broadly about a healthcare union and what we at SEIU do as a healthcare union, because representing healthcare employees is obviously, the big part of it, but we really see the work as more holistic than that, right? We see the work as fighting for racial and economic justice, right? For advocating for funding for safety net care, for equity in Medicaid access, for serving underserved communities, right? We believe in setting sectoral standards, that it's not enough for one facility that's unionized in a community to have good wages and benefits for the workers there, it really needs to be the entire community, the entire industry, right? We want to lift all of the boats and have good wages for all healthcare workers and good protection and health and safety standards for all healthcare workers. We're advocates of immigrants' rights. There are many, as everyone knows, I'm sure there are many, many immigrant workers in the healthcare sector. And we lobby and advocate for the rights of immigrant workers. We're advocates of healthcare. We were proponents of the ACA. We helped defend it in court. And we're advocates of reproductive freedom. And when I say we're advocates of these things, what I mean is that we engage in lobbying and we propose legislation. We advocate for regulations. We engage in litigation. We file briefs, with the Supreme Court, and we support other organizations that do this work. And that's what we do at SEIU. And so now I will turn it over to Ahmed for the next portion. Thank you.
Thank you, Steve, for such a good talk and such a helpful framework of how all of the different ways that unions operate, but also how the process of unionization actually works. I'm happy to also now dive in. I'm going to share my slides as well. Okay, perfect. Okay. All right, everybody, it is nice to meet you, and I look forward to hopefully more discussions as well after we finish these brief talks. So I'll be talking about the origins of house staff unions and then also the contemporary evidence base for labor unions as well. So as you all know, I am a resident at Brigham and Women's Hospital, and in June 2023, our hospital unionized, the house staff at Mass General Brigham unionized. In terms of conflicts of interest, so this actually happened a week before I started my residency, and I don't hold any leadership position within the union. So a lot of what I do is really to try to better understand the impact of unionization on healthcare and healthcare workers, and hopefully eventually also trying to get at its impact on patient outcomes as well. So a brief overview of my presentation, we're going to briefly go over the origins of house staff unions, some of which Steve also touched on. And then really this question of can resident physicians unionize? And this is something that comes up throughout history. And we'll briefly just touch on the arguments that either side tends to propose and then how it's played out throughout history. Then currently the evidence base that we do have on healthcare labor unions. So as it pertains to resident physicians, healthcare workers, workplace safety, and patient outcomes as well. All right, so in terms of the origins of house staff unions, I want you all to just pause for a moment and imagine yourself back in time in 1934 in New York City. So on the side, what we see here is a pediatric ward at Bellevue Hospital in New York, and then also the house staff at Bellevue Hospital in the early 1900s as well. So the work conditions at the time were such that a residency or an internship, as they called it, was about 1 to 2 years. And often the house staff at that time were not salaried. It's important to understand that this is 1934, so it's the height of the Great Depression in the US, and so economic security is at an all-time high. And for a lot of the house staff, during their residency, actually, they would rely on income from their parents to help support them because they weren't being paid by the hospitals. And so given that it's also the Great Depression, their parents are no longer actually able to fund their time in residency either, which made it a financial struggle for them. In terms of living conditions, there's a lot of concerns about poor food and living conditions. So at the time in New York, there were about 3 interns per room, staying on average in the hospital, in each hospital room that they were granted. But some rooms housed as many as 12 interns in one room. And the house staff have concerns about larceny and theft. They complain about inadequate toilet facilities that have poor plumbing. In terms of the food, they note that it lacked in vegetables and fruits, and that the hospital was actually beginning to incentivize reduced budgets for food as well. There was a practice at the time that was called ambulance service, where you would have an intern who was required to actually help with ambulances. And so they would sit in these ambulances and they would drive on the way to the hospital to help a patient. But the issue was they had no insurance. So if the ambulance got into any car accident or anything like that, there was no disability compensation, there was no insurance for the intern. It was just sort of an injury that you had to endure, or it was the end of your career at that time. Juxtapose this also with the transformation of hospitals as well. So the important thing to really understand about academic medical centers and nonprofit hospitals mainly is when they were first founded, many of them are charitable institutions. So they focus primarily on caring for the needy and the poor and the sick, that sort of intersection of demographic. But as we begin to hit the late 1800s and early 1900s, hospitals themselves are actually beginning to undergo a transformation. So now they're beginning to take care of all economic classes of the sick because we start to see medical procedures like EKGs or fluoroscopy being introduced where you can no longer actually bring it to the patient's doorstep at their home, which is what was done for a lot of high socioeconomic status patients. Now those patients had to come to the hospital to get care. So the volume of care is also going up as well. And there's no duty hour limits for the house staff. In terms of medical education, teaching rounds were uncommon. Most hospitals actually lacked functional libraries, despite the fact that the American Medical Association wrote it down as a requirement for residencies to have functional libraries in the hospital. And in terms of care quality, there was no standard guide or teaching on patient care. So house staff would come for a year, 2 years. There was no graduated curriculum or anything of that nature that existed at the time. And there was also just little ancillary staff support. So you would have interns who were running to send off a phlebotomy sample, but then they're not on the floor. And then an acute medical emergency happens and no one knows where to find the resident physician. And that caused some patient harm as well that interns were concerned about. So in New York City in 1934, a group of 66 interns get together from 26 different hospitals, and they meet to form what Steve had alluded to, which is the Intern Council of the Greater New York. And their goal was actually to just try to shed light on these issues so that they could begin to steer some kind of change. And this is the first publication of the Intern. You can actually find this in the Center for the History of Medicine at Harvard Medical School in the library. And what I found most profound actually is their opening line in quotations. If you look, it reads ad astra per aspera, which is a Latin phrase that means to the stars through difficulty. So this was believed to either be alluding to the challenging road that they foresaw in terms of trying to improve their training conditions, or the cultural norm within the profession that sort of accepted that doctors would have poor working conditions as interns and residents, and then eventually when you become an attending, things get better. For those on this call who are from Kansas, this is actually also the state of Kansas motto, which is an interesting history in and of itself. So in the first volume, the first issue, the interns actually write, during this formative period, many prominent members of the medical profession were consulted for their opinions and advice. It is accurate to state that a unanimity of opinion prevailed, and that was to form this group, the Intern Council of Greater New York. So while you would imagine that this effort was actually only coming from the house staff, they were actually reaching out to very prominent members of the profession, two of whom I've highlighted here who are their most trusted advisors. It's these two gentlemen. So this is Dr. Willard Rappleye on the left and Dr. John Hartwell on the right. So for those who don't recognize them, at the time, Dr. Rappleye is actually the Dean of Columbia School of Medicine. And Dr. Hartwell is the president of the New York Academy of Medicine, both of whom pen letters of support to this group, to form this group, saying that it has and it should have a place within the medical profession to improve conditions for both the house staff and also for patients as well. So I think far from an idea of this just being polarized without leadership, also consulting, some of the most prominent members had supported this group. So some early actions that they took and were able to accomplish by 1935 and 1936, house staff eventually go from being not salaried at all to being able to secure $15 per month to New York City hospital residents. They were able to upgrade medical libraries in numerous hospitals throughout the city and throughout the state. They successfully lobbied for the inclusion of residents under the New York State Workmen's Compensation Law. And they actually become outspoken critics on the discrimination of women residents as well, and to try to boost the inclusion of women residents in the profession. You'll find that throughout history, actually, for a lot of these house staff unions, they tend to also stand very heavily for social causes as well. So, for example, when the United States was considering healthcare for all under the Medicaid and Medicare bills that were being proposed in the in the 1950s and 1960s, house staff actually came out strongly in support for a universal healthcare coverage system, which unfortunately never came about, but they were public proponents of it. So I want us to fast forward from the 1930s now to the 1970s, where this question begins to arise of, can resident physicians actually unionize? And I think at the heart of a lot of this legal debate and toil is really this question of defining a resident physician. Is a resident physician a student, or are they an employee? So if you kind of think about it, right, for a resident physician, some argue that they're on this spectrum from the pre-medical student to the medical student to the resident physician. None of these individuals are independent practitioners by any sense of the definition per se. And they're all on a spectrum trying to become an attending physician, which is ultimately viewed as when you're done with training. So the argument here is that resident physicians are students learning their medical craft, and that residency is more graduate medical education. Another line of argument is that no, actually, resident physicians are a bit different from medical students and pre-medical students. They primarily train and work in the hospital. They are able to sign orders and they make independent medical decisions at times. And they're providing direct patient care, which the hospital is able to profit off of. And also, as I mentioned, the operating independently a good portion of the time during night float primarily. So if you come to the hospitals at night at an academic medical center, it's often rare that you'll see an attending there. It tends to be run by house staff primarily. And then also their salaries are actually taxable by the IRS. So there are these two schools of thought, and it comes to clash in NLRB cases in 1976 and 1999. So in 1976, Cedars-Sinai Hospital has a case against the House Officers Association at the time, where literally the arguments, to simplify them, come down to those exact points. The employer is arguing that resident physicians are students. The House staff are arguing that no, we're actually employees. And the decision at the time, in a 4-to-1 vote, the NLRB decides that they find that interns, residents, and clinical fellows, although they possess certain employee characteristics, are primarily students. So this creates a divide at the time between private employers and public employers. For public employers, house staff are actually able to still unionize. Within the private industry, however, they can't. And then an interesting case actually happens here in Boston. So in 1999, Boston had a hospital called Boston City Hospital, which was a public employer, and the BU house staff actually had a union with the Boston City Hospital. BMC actually took over Boston City Hospital, and BMC is technically a private medical center. So then they make the argument that actually, now that it's a private medical center, we no longer have to recognize this union. And this triggers a new case in front of the NLRB. The arguments look nearly identical to the ones in 1976. And at this time, in a 3-to-2 vote, the NLRB actually decides, the boards decided to overrule Cedars-Sinai to find that interns, residents, and fellows employed by BMC, while they may be students learning their chosen medical craft, are also employees within the meaning of Section 2.3 of the Act, and the Act that they're referring to is the NLRA, which Steve was mentioning. So going back to our original defining a resident physician as a student or employee, I think what you'll find is people tend to lean on one another, on one definition or the other, based on the political convenience of what they're trying to argue. But ultimately, I think the truth is more that resident physicians are both students and employees, but because they're employees, they have the right to unionize as well. So switching gears now to the current evidence base on healthcare labor unions. I think really the first question that comes to mind is how common even are house staff unions? So this was a study that we did, a cross-sectional work looking at NLRB union elections over time from 2011 to 2023. So prior to that, resident physicians, there just wasn't sufficient granularity to detect them in the data. But after that, you can actually follow their election results and outcomes. And we also looked across the country to see where house staff unions were and how many existed. So we actually went through over 1,900 programs, and we found 67 house staff unions in the US, 65 of which are in non-right to work laws states, which are essentially right to work laws have nothing to do with your right to work. It has everything to do with if you can be required to contribute union dues or not. And that's one way of financially making it more harder to unionize in states that have right to work laws. And most of them, as Steve noted, are actually represented by the CIR-SCIU, Committee of Interns, within the SCIU. So what we observe in the data is that mainly for house staff, 2023 had the most elections on date through the NLRB. So there is an element here of this being an accelerating phenomena. And then in terms of election results, house staff had among the highest win percentages that we look at in the study. So when we compare them to nurses and other healthcare workers, their win percentage is at a higher clip than those other two groups. And then finally, as well, to the point that Steve made, a lot of these election results are actually determined primarily by who casts a vote. So it has nothing to do with how many people are eligible to vote. It's about who actually casts a ballot to vote. And the majority vote is what determines the election result. Notably, there's highly variable turnout in these elections. So there's an election where there's 43% turnout, others that are 96, 97%. And what's notable here is that this determines if a whole residency is going to be unionized or not. And so I think there has to be also more attention in getting people engaged and getting them voting. Although I will say for some people, not voting is also an active choice that they make as well. Okay, so how common is unionization among healthcare workers in general? So in the US, nurses are among the most unionized healthcare workers, and then advanced practitioners and therapists as well. And physicians and dentists and technicians and support staff are actually among the least as well. And unionization is not, I mean, it's a prevalent thing, but it's not all too high in terms of numbers. There have been dates in history where we've seen much higher levels of unionization in the US. Unionizations associated with improved pay and also better benefits. So this is a study that we conducted where we looked and compared unionized healthcare workers to non-unionized healthcare workers. On this side, it favors the union in terms of how much people are earning per week. And this is all self-reported data. And on the left side, favors the non-union group. And what we find is overall, healthcare workers, it was associated with significantly higher pay. And then when you break this down by group, women actually have significantly higher pay. Men, actually, there's no significant difference between the two groups. It also varies by race and ethnicity, your occupation as well. So physicians and dentists and advanced practitioners, there weren't any differences, but among therapists, techs, nurses, we do see differences. And then it depends on where you live as well, on what region. In terms of other forms of compensation, so we looked at employer annual contribution to the health insurance plan. So for the non-unionized group, they had less contribution from their employer for health insurance. And then we looked at how many people actually have a full premium covered health insurance plan. And we see that's higher in the unionized group. And then finally, pension or other retirement benefits, also higher in the unionized group as well. So the impact of unions on patient outcomes. One thing I'll say before we dive into this is that the data here is quite limited. There aren't very many studies on this, and the studies that are done, I think some of them could be improved in terms of their quality. So I'm presenting the one that kind of stood out to me as one worth considering, but a lot more to be done here. So this is a study by Adam Dean and others in Health Affairs in 2022, and they look at the association between union status and resident COVID-19 mortality rate in US nursing homes. Notably, they define a unionized nursing facility as any nursing facility that has any union group. So it could be the nurses that are unionized, it could be the dietitians, the maintenance workers. Doesn't matter. Insofar as there's one unionized group, the entire facility is considered unionized. And they look from June 2020 to March 2021, and this is what they see in terms of their trend. So we see that COVID-19 mortality for nursing home residents, which was a big concern during the COVID-19 pandemic, is lower in the union group as compared to the non-union group. So they observe a 10.8% difference over time. And also they estimate about 8,000 fewer deaths from industry-wide unionization, had that been the case. They also try to understand worker COVID-19 infection rates. And what they end up finding is, again, lower worker COVID-19 infection rates as well. And they hypothesize that this is probably related to workers being able to advocate for better PPE and workplace safety. Finally, they also look as well in a different study. This is looking at unionization's impact on compliance with OSHA regulation. So OSHA is where we report any kind of workplace injury or hazards. And there's a form that you have to submit. And so that's their outcome of interest. And again, they're looking at any group that's unionized in these nursing homes. And what they end up finding is that this is a difference in different studies. So after the group unionizes, 2 years later, what they find is an increased likelihood of reporting data that's required by OSHA for workplace injuries. So that's a lot of the data that I wanted to share with you all. One just key tidbit, and then I'll close out, is just touching on key research limitations. So a lot of the data right now on unions feels a bit like comparing apples and oranges. And here's what I mean by that. Much of it tends to be cross-sectional. So you compare a union group to a non-union group, and they're often they're not causal studies that we're trying to draw causal inferences from. The issue is maybe these two groups are just fundamentally also different, right? The group that tried to unionize looks different than the non-union group, where maybe their work conditions were a bit worse. So maybe they were upset that they were underpaid. Maybe the work environment was unsafe as well, and they also felt overworked. Ideally, you want to compare them to a group that tried to unionize but wasn't able to successfully unionize. So a group that looks similar, because I think then we can begin to actually get at the causal impacts of unionization and its causal effect on patient outcomes and also workplace safety and other outcomes of interest too. So that's all I've got. I'd love to switch it over to Q&A from there.
Ahmed, thank you. Thank you, Steve. Two terrific presentations with a lot of information. We have a lot of good questions. I just want to encourage folks to put your questions in the Q&A if you haven't already. I would love to ask, as the moderator, take the prerogative of asking the first question. And it might not be a fair question because this isn't the job that either of you have, but if you could think a little bit about how to explore the moral and ethical questions that come up around unionization. And, you know, I think what you could think about it as, how does it impact patients? I think you could think about it in the way that one of our questions asked, which is, even if they're technically employees, legally employees, how staff are getting essentially public support for their training and what is their obligation to the public. And I think that might be specifically or particularly a question depending on circumstances. You know, is there a pandemic going on? Is there a local natural disaster that would or should require more of the staff at hospitals? So I don't know which one of you would like to take that. I'm gonna call on Steve first, and then we'll go to Ahmed.
Thanks. Well, you know, obviously I'm not a ethicist, you know, or an expert on medical ethics, but I will say this, you know, I think, well, let me say a few things, because I feel like you get these questions in the healthcare setting a lot about the morality and ethics of unionization. And I feel like they are always targeted at the worker, right? They're always targeted at the individual healthcare worker, as if they are solely responsible for, you know, the circumstances that they're in. And you don't hear as much questions about, well, you know, what are the ethics of paying poverty wages by an employer, right? What are the ethics of creating a work environment that's untenable for employees? I mean, you know, employers complain about, you know, this workforce crisis they're having and retention crisis. Well, you know, you don't pay enough and you have grueling work, right? That is going to cause a retention crisis. So I feel like those questions are often not directed broadly enough in terms of healthcare, you know, would be my sort of initial response to that. I don't personally, I don't think it's ethical to underpay people. And I think, people deserve fair pay for the work they're doing. And if they don't have that, they're not going to stay in that environment, right? And I will say I think Ahmed, put some excellent charts up about, effects on patient care too. I think unionization can be very beneficial to patient care. I mean, Modern Healthcare did a study that during the pandemic that unionized nursing homes had a 10% lower COVID mortality rate than non-unionized nursing homes. And that's likely because unionized workers are empowered to say things like, we need PPE, we need vaccinations, we need other things to protect the health and safety, not just of us, but of our patients as well.
Yeah, no, I would echo exactly those sentiments as well, Steve. And I think stepping back and thinking about the ethics of it. So I think really what this question is trying to get at is for healthcare workers, right? Like there's some element of a fiduciary responsibility where we are entrusted with the public's health and responding to the public's health. And we're also, our residency positions are funded by tax dollars as well. And I think there's nothing to me about like the collective organizing bit and having one voice or a collective voice that feels like it runs counter to that. And I think a lot of the data actually tends to support that it often is better for patients from a workplace safety standpoint and patient outcomes, although the data is quite limited to date. I think oftentimes when people talk about unions, I find that they automatically conflate unions with strikes. And I think there's something about strikes that feel sort of unethical in the healthcare realm primarily as well. And that's fundamentally, I would say, yes, unions can organize a strike. Workers technically can strike without unions. You are legally entitled to that as well. But it's not as common as when a working group is unionized. But I think that's a whole separate bucket. But in terms of actually forming a union, to be able to advocate either for the worker or for patients, which is often what we see come up as well, and patient care related issues, I feel like the two are actually more aligned than we would imagine it, I think, to be on face value.
Let me, if I could add back in there, because you mentioned strikes, that's a good point. I also think there's, for people who aren't directly engaged in a labor dispute, there's sort of a misconception of what a strike looks like and how it comes about, right? The strike is a culmination of a long series of events, right? I think there's a perception when you talk about a healthcare strike that, okay, you're in the OR and everyone drops their instruments, and walks out or climbs up on the table with a union sign, Norma Rae style, right? And it's just everyone's taken by surprise, and that's not how it works, right? If you're in a strike situation, you've been in negotiations for probably months, where you have not been able to resolve fundamental issues. The union has then asked their members to vote for strike authorization. Right, the members, the workers at that facility voted to authorize a strike. Even once they authorize, there's often negotiations for weeks or months even after that. But the employer's on notice from that point that there could be a strike. And then under federal law, a union has to give 10 days notice to any healthcare facility before going on strike. That only applies to healthcare, not any other industry for obvious reasons. But so it's not as if the conditions leading up to strike are suddenly a surprise, right? The employer plays a role too. They play a role in the failure to come to an agreement, and they have noticed that this is going to happen, and they, I think, would have an ethical obligation as well. I want to point out one other thing too, because there's a discussion often that came up, sort of cost, versus the investment in the employees. I just want to point out that our members in Canada, make good wages as well, right? And they have a publicly funded system that works. So the idea that fair wages for healthcare workers is a necessary drain on a healthcare system is, I think, just incorrect. I think there are so many issues with our healthcare system in the United States that it's really unfair to point to fair wages as being, a major concern.
Thank you both. We have a lot of good questions. I'm going to try to sort of pull some of them together. I think some of them are about the difference, as we've just talked about a little bit, between the actual collective bargaining process, the right to do that, and then the right to actually strike. And some relate to sort of the reasons that strikes ultimately happen, which is something you touched on, Steve, as well. And then and I'm sort of offering this by way of background because I think hearing from you, Steve, potentially, and also Ahmed, from your experience in your role as a resident as well, how conflicts might play out and how employers might actually benefit from having a union process. So that's a little vague, but you probably can answer a little bit of that.
I mean, I think, you know, the one thing about labor management relations is when you have a union, there's a forum for conflict to play out, right? That may not exist otherwise, right? There's a place for disputes to go. So when you're under contract, they go through an arbitration procedure, right? You don't have to worry about what else might happen. You know, the strikes happen during negotiations between contracts, but for the most part, during most of the time, you're under a collective bargaining agreement, and disputes are handled through a very set format, and it's equitable because everyone goes through the same process, right? So there's not a question of some people being treated differently than others through that process. And I think that, you know, having that process and a way to work out issues, and as I alluded to earlier, the idea of labor management committees, which are more free form, and a way to in a more informal way try to address problems, is something that can benefit everyone involved, right, including patients.
Yeah, no, I'd love to sort of take this question in a few parts, if that's okay. I think one is the point of why do healthcare workers strike? And they've actually done research on this, qualitative studies on what motivated the strike. And for a lot of healthcare workers, what they often cite is they feel as though they're unable to provide the best patient care that they can due to either inadequate facilities or lack of support by their employer or lack of support staff. So things like nursing to patient ratios being at a level that is unsafe for the patient, failure to improve sort of wages and benefits, and those coming up and having prolonged kind of conversations in many different avenues that they've tried to remediate those concerns. So that's often why people are striking. Now, thinking about, I think, the effects of these strikes when they do happen, which I will also say tends to be a rare occurrence. So there was a point in time actually where for resident physicians, they hadn't gone on strike for over 30 years. There was a meta-analysis that was done that looked at the impact of strikes globally. So they actually looked at the impact of healthcare worker strikes on patient outcomes, and what they find is no significant difference in patient mortality. And then they also look at the impact on patient morbidity during the strike period, and exact same thing, they find no, basically little to no impact on patient morbidity, which then leads one to wonder, like, how does that make any sense, right? Like, healthcare workers are leaving the work, so you'd imagine a patient would suffer because of it. But I think to Steve's point exactly is that oftentimes these are happening over a long period of time. And so the employer, one, legally has to get some type of forewarning about it. And they oftentimes will actually have contingency plans in place where they call in additional workers to fill in those voids during that time. I think the concern is that it's not sustainable over the long run. The bigger effect actually that strikes also have is more on the employee as well. So there's been a lot that's documented about moral injury for the provider, because for a lot of healthcare providers, right, like, our goal is not to leave the work and to just leave the patient behind. The circumstances had to have gotten severe enough that it called for something like that, or the group thought that. And also it can lead to erosion of trust with the public. And so actually, I think strikes tend to have more harmful effects on the healthcare worker, more than they tend to have on the patients themselves. Ideally, this ideal outcome is that both sides try to be reasonable and come to an agreement before it has to come to anything like a strike, but it does require both parties to make reasonable demands that can be achieved.
Thank you both. I want to pull together a couple of questions that will take us a step back from house staff. We have questions about unionization among nurses, and whether there's some sort of a gendered aspect of how the different rates of unionization might be happening. We have a question about attending physicians, not people who are not trainees, unionizing, and any trends in that. And then when we think about medical assistants or others working in hospital settings, how sort of unionization looks for them.
I don't know that I can give any broad trends. There are many, many organized nurses across the country. We represent nurses. There are many other unions that represent nurses. Attending is much less so. You know, there are many fewer physician unions. We do have some organized physicians in small pockets who are not house staff, but it's a much rarer occurrence. And there are more issues not with attendings, but with other physicians about whether there's an additional issue about whether they're employees or not. And there are actually antitrust issues that can arise in some physician organizing if they're not employed directly by a facility.
I think to the point about attendings, so for attending physicians, what's been a relatively new trend that's happened in healthcare, mainly since Obamacare, is actually that we're seeing a lot more attendings that are no longer the employer and they're now actually the employee. And that's something that's changing like quite literally in front of our very eyes and has happened over the past decade or two, where we're seeing the percentage actually of attending physicians who are employed begin to rise quite dramatically. It's gone from, I can't remember the numbers off the top of my head, but it was something about like less than 10% about 2 decades ago had an employer, and now it's about 60 to 70%. So I think certainly the labor relationship between attending physicians and hospitals are changing such that they're no longer really just having their own independent clinical practices. Many of them have an employer like Mass General Brigham, which then I think begets the point of how do you have a voice within such a large corporate conglomerate, where these hospitals now are healthcare systems that are often housing many different services, many different layers of leadership. And so for attending physicians, I think we're now actually seeing at Salem Hospital, attending physicians that are working on the unionization process, which kind of would have been unheard of in the past. But it's slowly becoming more of a phenomenon with more and more corporatization of healthcare.
That's great. We have just a couple minutes and I want to ask a last question. So the question is, coming from some of our viewers, how do folks who are already benefiting from a union support future unionization efforts with colleagues either in a different part of the healthcare field or pushing for better wages for medical assistants? How does that work sort of cross union within the sector?
I feel like I've gone first every time, Ahmed. I don't want to. Do you want to take that one first, or do you want me to go ahead?
Oh, you're good. You can feel free to go ahead.
Okay, it's a great question, and I really appreciate it. I mean, I think anything you can do to talk about your union experience, if you're a unionized worker, with other employees and give them support, join their meetings, join their rallies. And be open about how the union has benefited you. I think all of those things are great things that you can do. You know, joining a picket line if one of those goes up to support your colleagues who are either trying to form a union or who are in a labor dispute. And we always appreciate when other unions or other workers come and support the workers we represent who are trying to fight for a better living for themselves and their families.
Yeah, I think that's certainly one way, is just kind of sharing your experience. But another way also that has been documented in the literature too is that unions themselves and unionization has spillover effects in its local microenvironment as well. So take, for example, when the residents and house staff at Mass General Brigham unionized, you can bet that the residents at the Beth Israel began talking about unionizing as well. And so it also changed their compensation levels temporally, almost as tightly as it did for the Mass General Brigham residents. So I think oftentimes people are looking to their left and right. I think the actual medium has grown to a much larger scale now with social media. So I can't imagine that what happened from MGB was completely independent from what happened at Stanford when that house staff unionized, to then what happened at Penn and now Northwestern. I think there is certainly an element of looking at your peers and seeing what they're doing, and people that are more vocal on social media, such that it's made the process, I think, a bit more understandable and palatable for other healthcare workers as well.
All right, we're going to have to leave it there. Thank you both. a huge thank you to both of our speakers. You have very busy lives. You've given us a lot of your time and a lot of information to think about. We will have a fully captioned video of this event up on the website within a couple of weeks, and it will be sent to all of the registrants. Thank you again, and I wish we could have gotten to more of your questions. Thanks,
Thank
everybody.
you.